Unfortunately, to date, we have not seen regulatory approval of a specific targeted therapeutic for KRAS mutant lung cancers. We certainly hope that will change in the future. But for now, the systemic therapy options that are available to these patients include, of course, chemotherapy, immunotherapy, or a combination of both in the upfront setting, and the other second and third line options that are approved for non-small cell lung cancers in general.
In terms of key EGFR TKIs and KRAS mutant non-small cell lung cancer, that's not really a practice that's used anymore. So, you know, for afatinib is a second generation EGFR TKI that's approved, you know, after platinum-based chemotherapy in squamous non-small cell lung cancer based upon a modest benefit that was observed. In lung adenocarcinoma, erlotinib used to be approved in lung adenocarcinoma after progression on platinum-based chemotherapy, even without EGFR mutation. So sometimes that was used, but it's really not used anymore, and it really doesn't particularly work in KRAS mutant non-small cell lung cancer. Now, there is some interesting data, and I think what's more relevant now is ERBB pathway inhibition with EGFR and HER2 on impacting GDP and GTP loading in terms of shifting KRAS in the GDP bound state that may help synergize in certain settings with direct KRAS G12C inhibitors. So that's where I see the future heading with EGFR TKIs and KRAS mutant non-small cell lung cancer as part of a combinatorial approach with direct KRAS inhibition or other combination treatments targeting the RAS-RAF-MAP kinase pathway, rather than it is a single agent in KRAS mutant non-small cell lung cancer, where really with the changing landscape of much more effective therapies, its role has been substantially diminished.
For many molecular drivers, the immune therapies are less effective. So if you looked at EGFR, LCOS1, RET, probably MET, the immune therapies don't seem to work so well. For KRAS mutations and BRAF mutations, the immunotherapies tend to work at about the same frequency in KRAS mutants as in tumors that don't have any actionable driver. So immunotherapy is a good option for patients that have KRAS mutations and BRAF mutations. And for those, the selection would primarily be based on the PD-L1 expression, whereas high PD-L1 patients with KRAS mutations could receive a checkpoint inhibitor alone, whereas those with lower PD-L1 expression might receive a checkpoint inhibitor plus chemotherapy. Now, there are some co-occurring molecular changes in KRAS, such as STK11 or KEAP1, where the chance that an immunotherapy might work tend to be low. The best thing to do in those cases is unknown. But the likelihood that immunotherapy will work in the presence of a KRAS mutation plus a KEAP1 mutation or an LKB1 mutation may be lower, but we don't have a specific thing to do for them at the moment.